Howdy YouTube family, it's Bold CRNA coming to you again with another day's topic. Today we're going to be talking about what is pimping. This is something that I had to learn when I first started CRNA school. I had no idea what this term meant, and when they first talked about it in class first semester, I was very put off by the idea that I was going to get pimped in clinical. So I also started using this lingo as I went along, and I realized a lot of you followers who are keeping up with me also don't know what pimping is and are sending me DMs occasionally asking me like, what are you saying when you mention pimping? So let's get into how, as a CRNA student, you get pimped. First things first, it's not sexual. You're not being pimped as in a pimp and a hoe. Not in the literal sense, I should say. Maybe figuratively. Now this term dates back many, many years. I'm going to give you the definition version first before I talk about literally what it means and what I've experienced it to mean. On idealmedicalcare.org it says, pimping is a teaching technique in which a student is grilled with rapid-fire questions, often about obscure medical minutiae. These much-feared public interrogation sessions can be so malicious that the student may be left crying in front of peers, staff, and patients. That's pretty accurate. Yeah, that's essentially what pimping is. And if you're going into CRNA school or med school or anything like that, medical training, you're going to experience pimping. It is very popular. It used to be more popular than it is now in a society where we're a lot more aware of appropriate behavior and emotional trauma and things like that. That used to not be a focus that people cared about. There's less people trying to pimp, or at least when they pimp you, they're trying to do it in a little bit more of a polite way so that it doesn't come off as much as the trauma. But it still happens. It's still very much a part of your training, and you will experience it. So let's talk a little bit about my experiences with it. From my own experience, I would say that typically your older providers who are going to be clinically instructing you will be more likely to pimp you. And they're also more likely to be ones who will pimp you aggressively in the sense that you may get very upset and cry. Or you may get rapid fire questions, and they may continue to ask you more questions that are even deeper onto the topic that you already have shown that you're not very knowledgeable on. So they're going to continue to dig into it just to really hammer it home how stupid you are and how much you don't know about this topic that they're talking about. There are some ways that it can be constructive, in the sense that it causes enough trauma that you probably will go look up that information and probably remember it forever after that. And I assume that is the goal. I'm sure the goal is not just to be malicious. At least I hope that's not the goal for most clinicians who are teaching. Maybe there's some maliciousness in there, I don't know. But I think the whole perception is if you have enough shame and fear and sadness about having information wrong, and they make you feel bad enough about it, you will go home, you'll study it, you'll remember it, you'll know it for the next time. When you need that information, maybe for some patient safety intervention or something that you're needing to do for the patients, then maybe you'll remember it. Now, my personal experiences, I'll say the very first time I got pimped, I walked into clinical the very first day and I was nervous. I'm telling you, I didn't sleep the night before. We just started our second year of the program. My program was front loaded, so the first year of the program was totally didactic, where you're just learning in the classroom Monday through Friday, and you're studying and you're taking tests and you're just trying to get ready. You do some sim lab stuff, you work on sim lab mannequins and sim labs that have anesthesia machines where you do anesthesia checks and do things like that. You're not actually in the hospital placing hands on real patients yet until you start second year, which is when you hit the ground running with a lot of clinicals. And in my program, my first rotation I went to, I walked in the day of, like I said, very nervous, couldn't eat, couldn't keep any food down. And I was thinking in my head, like, surely I'm making this out to be worse than it's going to be. I'm sure I'm going to step in here and they're going to be nice people who are just going to be like, oh, it's your very first day of clinical ever. You're just going to shadow today. Don't worry about it. I got you. Well, unlucky for me, the very first person who saw me as I walked in the front door was a physician anesthesiologist who was fresh out of residency, which kind of goes counterintuitive to what I said earlier about usually older physicians are ones who pimp you really hard. This particular one is one of the rare few who was fresh out of residency, and I suppose he must still be reeling from trauma from his own pimping, so that he feels like he needs to keep, you know, this cycle going. So he pulls me to the side, and I don't think he even introduced himself or even said welcome or anything like that. I think he just pulled me to the side in the pre-op area and said, off the top of your head, tell me from start to finish an exact way that you would do a pre-operative assessment for anesthesia. And of course, you will have gone over some of these topics in your didactic portion, and you probably will have even done it on a fellow classmate in a simulation lab. But your first day of clinical, when you're terrified and nervous and it's 5:30, 6 a.m., and somebody who is an experienced clinician pulls you to the side and is kind of like really sternly looking at you, telling you to recite off the top of your head a start to finish full in-depth pre-op anesthesia assessment, you kind of blank a little bit. And I started to say, you know, my head-to-toe assessment and stuff, and really what I reverted back to was my head-to-toe assessment that I remembered from my ICU days, which I'd done 4 years of ICU training, so I had that nailed down. Even when I'm nervous, I know how to do my ICU assessment. So I start going through my ICU assessment, and I get to pedal pulses. I say, like, I'm gonna check pedal pulses, which is what I always did in the ICU, like every 4 hours, and he flipped out on me. You're gonna check pedal pulses on a laparoscopic cholecystectomy healthy 27-year-old patient? What's the matter with you? I just started like really getting into me. So as he's berating me and letting me know that this is not internal medicine, that I'm in anesthesia now, what kind of assessment are you trying to do? Are you even sure you're in the right department? Where did you know you went to anesthesia school and not internal medicine school, and all this kind of stuff? He just started really just making sure I felt terrible about myself. A CRNA swoops in and she sees him. This is in a public arena, of course, in the middle of the pre-op center where the patients are all around us with little curtains that are pulled open. They can see it. And the nurses in pre-op and the other physician anesthesiologists and the CRNAs are all going to see their patients. Everyone can watch this happening. And so she swoops in and she says, "Hey, are you a new SRNA? Have you been assigned to a room yet today?" And I said, "No." And she pretty much interrupts him in the middle of speaking, and she says, "Oh, you know what? I don't have a student with me today. Why don't you come with me?" And she grabs me and she pulls me in with her, and I was like, "Oh, thank you so much for taking me with you. I really needed a room to go to today, and I needed a little direction." And she goes, "Well," she said, "actually, I don't really have a case right now, but I'm just trying to save you from him." She was like, "He's kind of a rough guy to deal with, and he's hard on students all the time, so I was just trying to save you from that situation." She was like, "I don't even have a case for you to go do, so you need to go find something to go do now, but I got you away from him for a minute." And I was like, so panicked at that point, because I'm thinking, oh my God, like I've just been thrown out to the wolves here. Like I don't even have anywhere to go. I don't have a case assigned to me. Even this CRNA who was trying to save me was really just saving me for the moment. They're not really gonna take me under the wing the whole day. They're just telling me like, okay, go to the board and figure out what you wanna do. I'm looking at this big board that doesn't make any sense to me, because as an ICU nurse, you're not trained on OR boards and how they organize them all over the place. They look chaotic. They've got different names everywhere. They got scrub tech names and circulator names and surgeons names and anesthesia's names, and they've got the long crazy looking procedure names, and they're usually on magnets or something that they keep moving around the board to different room numbers, and the ORs are always designed like a crazy labyrinth maze. So I'm starting to wander around and stuff. Unlucky for me, this physician anesthesiologist who was giving me a hard time in pre-op wanders up to the board at that point, sees that I'm not with that CRNA anymore, that I'm not in a case, and says, "You know what, if you don't have anything to do, then you can come help me in pre-op today, since you don't seem to know how to do a pre-op assessment. Today you're gonna learn." So I pretty much spent the entire day in pre-op, and I did pre-op assessments and IV placements all day long, over and over and over again. And he gave me a hard time pretty much the whole time. He criticized most of what I did, and would kind of give me smart aleck remarks often. That was just my first day in clinical and just a little example of pimping. And the key to pimping questions is if you don't know the answer, don't lie. Don't try and make up an answer that's not correct, because they'll know the correct answer and they will nail you if you try and lie to them. And then they'll really dig into you. So the key is, as a new student who's trying to answer these types of questions and stay on your feet, if you really don't know the answer, say you don't know. Or, and when I say you don't know, don't just say I don't know, because that's a really bad answer. What you say is, I am not 100% sure on the answer for that, but I do have the resource to look that up, and if you would give me one moment, I'll look that up and I will be right back with the correct answer. Sometimes they'll respond okay to that. Sometimes they'll say, look it up then, and like they're gonna be irritated at you and they're probably gonna have a little bit of an attitude, but they'll say like, look it up. And you have probably 1 minute to look that answer up in your Vargo app or whatever medical textbook, app or something that you have with you that you can look up really quickly and figure out your answer. There are other times where they're going to tell you, like, if you don't know this answer and you can't just look it up if you're the only one in this room because you need to know it in the moment, then you need to go over here and sit down in the corner and you just need to observe for today because you're not safe to practice anesthesia today. Or even may throw you out of the room. There have been some providers who will say, you need to get out of this room then, go sit down in pre-op or something and read a book, and there have even been some, this has never happened to me, but I have been at rotations where students have been sent home and they've been told, like, you're not safe to practice anesthesia, period. I want you out of this room. I want you, you need to go home out of this hospital. And then, of course, if that happens, your program's going to get a letter, or a phone call or an email. Your program director is going to get that phone call, and they're going to get notified that you showed up for clinical, what's going to be considered unsafe and potentially jeopardizing patients because you don't remember certain information that they think is important and things like that, which potentially could jeopardize your position in that program. If that happens, more than once or something, you're probably going to get dismissed from your program. So that's a really frightening idea, and that's what makes SRNAs and medical students and stuff so nervous, is because you don't want to get penalized, and potentially removed from your training if you're not able to answer very difficult pimping type questions by a clinician. And ultimately, it's going to be their word against yours when it comes down to it, and somebody's saying like, well, why didn't you know this, and this? Well, a lot of times it's going to be what that clinician says you didn't remember or answered incorrectly versus what you say. And the person they're probably going to believe is the clinician and not really you. So that's kind of why pimping can make students very anxious. About 6 months later, I was working in another rotation center doing general surgery rotation, and there was one CRNA that everyone knew that you did not want to work with, because this particular CRNA was very hard on students. He had good intentions, I think, at his heart, that he just wanted you to be like the best of the best of the best, and he was going to make sure and grind you down until you became that. But the process of being ground down into that is traumatic and usually left students in tears and upset. No one wanted to be with this person, and I had the luck of being placed with him one day. He speaks at you in a tone of voice that's very aggressive. That's one element of making it very difficult dealing with a preceptor like that, especially one who likes to pimp you, is when they're even just speaking to you about basic things and not even asking you questions. If they're speaking so aggressively at you and so stern and looking at you, and their facial expressions and their body language is projecting this kind of like aggression and like they're just not happy with you, even when you're not doing anything, that already puts you on edge. And then when they start drilling you with questions, and then when you answer the question, they're like, well, tell me your research source for your answer for that question. And you're like, I don't have a research source off the top of my head. And they're like, well, what kind of clinician are you? You're not practicing evidence-based practice. You're just doing things because you think you remember it. Where's your research? That's typically how he behaved, which made it very difficult to work with him. And he would do it in public spaces, of course, where everyone around you was watching, you were being embarrassed in front of everyone. And so I remember working with him in particular, and all day it was just, I would suggest something and he'd be like, well, why would you do that? And then I would explain my why, and he'd be like, well, why would you explain that why like that? And where did that come from? And if you did this instead, why would this happen? It was just always this constant stress. And I remember one of the scrub techs came up to me one day, and she came up to me and she whispered, "I'm sorry," and she was pretty much pitied me, and I'm sure that all the staff pitied me. And it was just one of those situations where you're in where everyone around you is watching what's happening, and they know they can't do anything about it, and they definitely dare not speak up and try and say anything to, you know, tell the CRNA or the physician anesthesiologist, whoever's giving you a hard time. You know, they're not going to speak up and like intervene too much because they're not going to draw the fire from that person. So you're kind of just stuck for the whole day with that person. But they do pity you, and they do like quietly wish that you know, have a good day tomorrow or something instead. So there are those positive vibes that get said to you, but that's just an example of pimping. I know this is kind of like a long-winded explanation, but a lot of people are confused by it, and they want to know the logistics of exactly what it means and what experiences I've had when I've been pimped. That's pretty much my experiences. It went on for the whole program, and it's going to happen to you all throughout your CRNA training. What I vow is that I will never do that to students. I will never be that kind of person who grills you and drills you down and makes you feel small and makes you feel insignificant. Even if there's certain answers that you can't remember, or, you know, things that you don't do well, or you miss your intubation or whatever that may happen. It's part of the learning process. I will ask questions for students, and I will, you know, facilitate learning, because you're there to learn. You're not there just to watch me do stuff. But I'm not there to make you feel bad about yourself. And I think that's where pimping really needs to go the way of the dinosaur, is because the term itself infers that it's malicious and uncomfortable and makes the student feel bad. And I'm not there to project any bad feelings or make you feel worse. You're already stressed out. You're already overworked, stressed out SRNA. I'm not trying to add to that. So that's what I vow, is in the future when I have students, I'm not going to behave like that. What did you guys think about the pimping video? Do you guys think that pimping is something that should go the way of the dinosaur like I do, or do you think it helped you learn? You clinicians out there who are already out into practice, do you pimp students? And if you don't, why don't you? Do you feel like I do about it, that it's just kind of traumatic and students don't really learn that well from it? Or there's better ways that we could teach students without all of the PTSD? If you watched this far along, you better hit that like button and hit that subscribe button and come back, because every Monday I post new videos, and we'll have more stuff like this for you to enjoy next week. And that's Bolt out.